Hello, my name's Melissa and I'm an F2 in Margate at the moment. I'm going to talk to you about general surgery and we'll also briefly go through about some top tips as an F1 in general surgery. So the teaching format for this session will be going through some upper gastrointestinal cases and after that some lower GI cases. And then we'll talk about the top tips for doing surgery in F1. So, first off, the upper GI cases. Case 1, 45-year-old female presents with a history of right upper quadrant abdominal pain associated with nausea and vomiting. She reports the pain is brought on 2 to 3 hours after a meal and describes the pain as a band that radiates around the upper abdomen. She's obese. And on examination, her abdomen's soft with some right upper quadrant tenderness. She's pyrexial. She's, in terms of her heart rate and BP, she's stable. And she's saturating at 97% room air. So what are the differentials you can think of right now is probably dyspepsia or gastric reflux because it's brought on after a meal. Cholecystitis is also one differential. Pancreatitis and renal colic is also another possibility. So you do her bloods and her white cell count is raised. ALP is showing an obstructive picture. Amylase is normal, so rules out pancreatitis. Inflammatory markers are also raised. So you perform an ultrasound abdomen and it notes that the gallstone is present in the gallbladder. So the gallbladder walls thicken, which shows that there's some inflammation going on in the gallbladder. And the common bowel duct is not dilated. So if the CBD duct is dilated, it notes that there is a obstruction further down the common bowel duct, and that's when you get involvement of deranged bilirubin and patients jaundiced, and they have also pale colored stools. So the risk factors for gallstones, all of you should know, the 5 Fs, the fat, 40, female, fertile, and fair, which are the risk factors. And as you can see in the scan here, the ultrasound notes some gallstones present in the gallbladder. Right, so just to briefly go through, some patients usually present with symptom of biliary colic. So they have a fatty meal and then they get these abdominal pain in the right upper quadrant that goes away after a few hours. That's because the gallbladder contracts following stimulation by hormone cholecystokinin, which is produced by the duodenum and small intestine in response to fat present in the lumen of the bowel. And in terms of pathology for cholecystitis, the stone is usually impacted in the gallbladder outlet and the gallbladder wall becomes inflamed, as we note in the ultrasound scan. So sometimes it tends to be impacted in the Hartmann's pouch or the cystic ducts. And the gallbladder then fills with pus, which is frequently sterile on culture. Investigations you can do is an ultrasound abdomen or CT abdomen. You should do a CT, especially if you're worried of a empyema of the gallbladder, where you're thinking of probably doing a cholecystostomy. So cholecystostomy is an IR guided drainage of the gallbladder. So you can do it either under ultrasound or CT. Another investigation you could do for cholecystitis is an MRCP, which is a visualization of the biliary tree. ERCP is a visualization of the ducts and also allows you to extract the stone. So basically, ERCP involves a camera down the upper GI tract, and basically they inject a dye into the biliary tree, and then they take some X-rays of the abdomen, and where you can see the dye stop, and then you know that there's a obstruction there, and you can retrieve the stone. In terms of management, you can give them some good analgesia, give them some antibiotics. Usually in my trust we give Coamox first line, and if they don't improve then you move on to piperacillin and tazobactam, and if the patient still does not improve, give them meropenem. And we briefly talked about empyema in the gallbladder. Also, these patients should have a laparoscopic cholecystectomy. So you should do a lap cholecystectomy at least within 1 week of diagnosis. That is the NICE guidelines. Also, in cholecystitis patients, you can often palpate a mass in the right upper quadrant. That shows that because of the distension and inflamed gallbladder that's wrapped in inflammatory adhesions, that's why you can palpate it. Also, you should advise them on some low-fat diet. A complication of gallstone could be gallstone ileus. So that means the gallstone ulcerates through the wall of the gallbladder into the duodenum, so it forms a fistula from the gallbladder into the duodenum. It passes through the small bowel into the distal ileum, resulting in a mechanical obstruction known as gallstone ileus. And that requires surgery in terms of the management for gallstone ileus. Next case, a 56-year-old male presented with some gastric abdominal pain which radiates to the back. The abdominal pain came on suddenly and it's severe and constant. He hasn't been able to have any food or water. He's nauseous and is vomiting. He feels feverish and weak. He drinks a lot of alcohol each week. And when you examine him, he's tender in the epigastric region with some guarding. In terms of his observations, he's pyraxial, he's hypotensive, tachycardic, has a high rest rate, and is currently requiring oxygen of 2 liters. What differentials you can think of at this stage? Probably acute cholecystitis, also pancreatitis, peptic ulcer that could have perforated because the pain came on suddenly. Also, you need to exclude a myocardial infarction, where patients can present with abdominal pain. You do his bloods, and it shows elevated inflammatory markers. His amylase is raised, in keeping with pancreatitis. Calcium is also low. ECG notes sinus tachycardia, and CT reports necrotizing pancreatitis. So the most well-known mnemonic for the causes of pancreatitis would be "I get smashed," and I'm sure all of you are familiar with it. Gallstones tend to be the most common cause of this pancreatitis. And in terms of the presentation, they can come in with abdominal pain, tachycardia, fever, hypotension. They can also have the gray Turner sign, which is bruising at the flanks, or Cullen sign, which is bruising at the periumbilical region. And if they have the gray Turner sign or Cullen sign, you should raise your suspicion on hemorrhagic pancreatitis. Always make sure you score them based on the Glasgow IMRI criteria for acute pancreatitis. And if they score 3 or more in the first 48 hours, you need to let HD or ITU know that this patient is very ill. And the investigations do the full blood count, LFTs, albumins, do a lipid screen as well. So you want to know if the pancreatitis is caused by raised triglycerides. Always perform amylase, CRP, calcium, urea, and LDH. Do an ABG. Also do an ultrasound scan to assess if there's any gallstones present, which could be the cause of the pancreatitis. CT to assess severity, especially if they're still persistently spiking temperatures and persistently having high CRP. It should raise your suspicion of necrotizing pancreatitis. Ideally, perform it 72 hours after onset of symptoms. Because the CT scan, which is performed within the first 48 hours of symptoms, may be completely normal. And management should be by fluid resuscitation. Make sure you do your A, B, C, D, E assessment. Give them some oxygen. Ensure they have good analgesia. These patients tend to require pain team referral because it can be very difficult to manage in terms of control of the pain. Put an NG tube down as well. Give them some antibiotics, especially if they have high CRP and raised inflammatory markers, which gives you a suspicion of necrotizing pancreatitis. You tend to keep these patients nil by mouth to reduce the chances of getting aspiration pneumonia, or also to rest the bowels. So make sure they have some nutritional support, but obviously depending on how severe the pain is and if they're getting If they're improving, then you may allow them to start slow diets. So you increase the diet slowly, start them on free fluids so they can have coffee, tea, and then progress to some soft diet like yogurt, ice cream, and then you progress to more solid foods. Also, ensure they have prophylactic dose Claxane and TED stockings because of the hyperinflammatory state. They tend to be more predisposed of having PEs and develop clots. So complications of pancreatitis would be shock. These patients tend to urge space a lot, so make sure they have loads of IV fluids running. And also develop ARDS, sepsis, renal failure due to poor circulation of the fluid. And late complications would be collection, pseudocyst. So in terms of these, it can have a pressure effect on the stomach with fullness. That's why if you put an NG tube down, it reduces their risk of aspiration, particularly with that extra pressure on the stomach. Abscess formation and thrombosis, as we said, more commonly in the splenic and gastroduodenal arteries. So as you can see on this CT, N is the mark for the area where it's necrotic. So this is the pancreas, and some fluid collection around here. And it's necrotic region in the pancreatic area. So case 3, 68-year-old male came in with upper abdominal pain of extreme severity. Pain is worse on movement and associated with nausea and vomiting. Has had 3 episodes of hematemesis. He's got a background of osteoarthritis. In terms of observations, he's apyrexial but tachycardic and hypotensive. Respiratory rate is raised, and he's also got a saturation of 97 on 2 liters of oxygen. And when you examine him, he's got rebound tenderness with abdominal rigidity and reduced bowel sounds. So he's a pretty unstable patient at the moment. In terms of differentials, it could be acute cholecystitis, pancreatitis, myocardial infarction, also could be a perforated peptic ulcer. He's also been vomiting, so it could be a Mallory-Weiss tear, which is superficial mucosal tear of the esophagus, Boerhaave syndrome, transmural tear of the distal esophagus. There's this triad for Boerhaave syndrome, which is vomiting, abdominal or chest pain, and subcutaneous emphysema. However, it's usually absent, so it's very difficult to diagnose patients with Boerhaave syndrome based on just the clinical findings. And when you do the bloods, his HB has dropped to 79, ALP and ALT are all right, amylase is okay, CRP is slightly raised, 47, and if you looked at his erect chest x-ray, it gives you a spot diagnosis of perforation, because you can see the pneumoperitoneum, so air on the diaphragm, some wriggler sign present in bowels as well. So diagnosis as perforated peptic ulcer. So he's on, if you can remember, he's got background of osteoarthritis, so chances are he's been taking some painkillers, and it could be NSAIDs related. So make sure you always check with patients if they're on ibuprofen and if they've got PPI cover. Management wise, we mentioned A to E assessment. Make sure you give them some fluids, keep them nil by mouth just in case they're going for emergency surgery. Prepare them for surgery, group and screen, some good analgesias, and give them some, and put down an NG tube as well. You're also going to need to start an IV PPI infusion. So surgery would involve basically suturing part of the omentum onto the site of perforation, and also washing out the abdomen. Moving on to lower GI cases. Case 4, 70-year-old female present with abdominal pain and abdominal distension, which is a very common presentation in elderly. She has been vomiting some bile-colored vomit. Reports she has not opened her bowels for 5 days. Got a background of hysterectomy and appendicectomy. In terms of her observations, they all seem fine. On examination, she's distended, has generalized tenderness, and reduced bowel sounds. differentials, constipation. She hasn't opened her bowels for a while. It could be adhesional bowel obstruction based on her past surgical history. Also, it could be a volvulus or malignancy. Patients with bowel obstruction, always make sure you exclude malignancy. And when you do her bloods, it shows a white cell count of 9, and also some, she's also very dry, urea of 8, creatinine of 150. Her lactate notes 1.2, not particularly concerned of ischemic bowel based on that lactate. And you do a abdominal x-ray and note some dilated small bowel. So I think the diagnosis definitely would be you have a high suspicion of adhesions. So let's talk about bowel obstruction. You probably see this, especially as an F1 in general surgery. The causes can be categorized based on small bowel and large bowel obstruction. So small bowel obstruction causes are adhesions, hernia, large bowel obstruction, colorectal neoplasia, diverticular stricture, volvulus, constipation. So you do the electrolytes because they tend to have deranged electrolytes due to dehydration. Check the lactate, exclude strangulated bowel obstruction. Prepared, make sure they're prepared for surgery if they need it. Group and screen clotting. Do an abdominal x-ray, erect chest x-ray to exclude perforation, and do CT abdomen to identify the transition point for the obstruction. So where it starts and where it ends. And also another investigation you can do is a gastrographin swallow study. So gastrographin is both it's a hypertonic solution, so it's both therapeutic and investigative. In what you can do is basically give the patient 100 mils of gastrographin through the NG which you've inserted, and take a serial abdominal x-ray, so one at 2 hours post gastrographin and one at 4 hours after that. So it's just to see the flow of gastrographin through the lower GI tract and for you to identify where the transition point is in terms of the obstruction, or if there's a stricture present, you can identify that location. And in management, keep them nil by mouth, make sure they have sufficient fluids because they're dehydrated. Put an NG tube. Sometimes NG tube can also be used to deflate that obstruction. Give them some analgesia. Mention gastrographin. Ensure they have got good nutrition. Surgery, you can do adhesionolysis, colectomy, or Hartmann's. And the indication for surgery is usually closed loop obstruction, malignancy, strangulation or perforation, or failure of conservative management. So I'm going to talk to you now about the ileocecal valve, because then it gives you, usually when surgeons interpret the abdominal x-ray, they tend to think about the ileocecal valve. So when the ileocecal valve is competent and you have an obstruction further down the line, so it could be in the sigmoid colon, or it could be in the transverse colon. So when you have it distally to the ileocecal valve and it's competent and the obstruction is distal to the ileocecal valve, you will only notice dilatation in the large bowel without involvement of the small bowel. Whereas if the ileocecal valve is incompetent, you'll see dilated large bowel and dilated small bowel. And that's when NG tube is useful to help relieve patient symptoms and deflate the obstruction. So you can put, whereas like if the ileocecal valve is competent and the small bowels is not dilated and you put an NG tube down, it will not provide as much benefit. I hope that clarifies it. Right. So we're just going to briefly go through some colorectal surgeries and different types of colectomies. So first one, right colectomy. Right hemicolectomy is for cecal tumors and ascending colon tumors. So basically remove the ascending colon and part of the transverse colon, and then you do a anastomosis, primary anastomosis, which is an ileocolic anastomosis. And left hemicolectomy, you remove the left side of the colon, so the descending colon, and you perform a colon-to-colon anastomosis. Sigmoid colectomy for sigmoid colonic tumors, and you remove the part of the sigmoid and perform primary anastomosis between the colon and the rectum, so it's called a colorectal anastomosis. Then you have the anterior resection, which is for high rectal tumors, meaning tumors more than 5 centimeters from the anus. So you remove the you remove the part of the rectum, but it leaves the rectal sphincter. You have a defunctioning root ileostomy, so you can anastomose the colon to the rectum, the next bit of the rectum. And then you have the abdominal perineal resection, is for low rectal tumors, so tumors less than 5 centimeters from the anus. You excise the distal colon, the rectum, and the anal sphincter, and this results in a permanent colostomy, so they have a stoma. And Hartmann's procedure is a resection of the rectosigmoid colon, so the rectum and the sigmoid colon, and closure of the anal rectal stum, as you can see here, and they're the form of an ankylostommy. But you can have a reversal of the Hartmann, so you basically anastomose, you bring down that stoma, and you anastomose it back to the rectum. Next case is a 16-year-old female who came in with lower abdominal pain associated with nausea and vomiting. She reports that it started in the center of the abdomen and moved to the right side. And this pain is exacerbated by movement. She's had some diarrhea 3 days ago, but no abnormal PV discharge bleeding, and reports that her periods are regular, no past medical history. Obs-wise, she seems stable, slightly hypotensive, but it's common in young females. You tend to get them to have lower blood pressure, but always check with the patient. On examination, she's tender in the right iliac fossa with no guarding. The differentials you can think of, because she's got diarrhea previously, could be gastroenteritis, could be IBD, could also be ureteric stones. Also, don't forget to exclude some gynecological conditions like ectopic pregnancy, ovarian cysts, acute salpingitis, PID. So make sure you do a pregnancy test and also do a urine dip. And also another differential could be appendicitis. Mesenteric adenitis is another differential, but usually in younger children. So appendicitis is a diagnosis. So her white cell count is borderline, CRP is raised, urine was negative for pregnancy test, and ultrasound noted appendicitis. So patients with appendicitis, they tend to present with sometimes pyrexia, tachycardia, flushed appearance, also tenderness in McBurney's point. So McBurney's point is 2/3 from the umbilicus to the ACEs. In terms of imaging, you do ultrasound abdomen first, but if the diagnosis is unclear, you tend to do a CT abdomen. Management-wise, make sure they have some sufficient fluids, start them on some antibiotics, which can be metronidazole and gentamicin. Give them some good analgesia, and most likely perform an appendicectomy. So usually gold standard is a laparoscopic appendicectomy. It's very useful in females for visualization of the uterus and ovaries, and is also favored in obese patients. Open appendicectomies tend to be done in pregnancy. Appendix should be sent to histology once it's been resected. It's just to exclude malignancies such as carcinoid adenocarcinoma or mucinous cystoadenoma. The image just shows that the position of appendix can change. And this is the RCS guidelines on right iliac fossa pain or appendicitis. I just want to pay attention if you think or you suspect an elderly patient has appendicitis, you have a lower threshold to perform a CT, because there are a lot of things that can happen in elderly patients, just to exclude any other pathology. Right. Next case, 68-year-old male presents with a 5-day history of lower abdominal pain. The pain started in the center but has moved to the left side of the abdomen. He reports 2 episodes of fresh PR bleeding. He also had nausea but no vomiting. Has had episodes of diarrhea about a week ago. Has a background of hypertension and type 2 diabetes. He is apyrexial, has a heart rate of 75, blood pressure is stable, and he's saturating fine in room air. When you examine him, his abdomen is soft but tender in the left iliac fossa. You perform a PR exam, so make sure you perform a PR exam whenever patient has PR bleeding, just to find out the cause. So he's got no skin tags or hemorrhoids visible, fresh blood on glove finger, anal tone is normal, prostate is smooth and not enlarged. So differentials that you can think of would be malignancy, IBD, diverticulitis, hemorrhoids, although we've excluded based on our examination, and angiodysplasia. So bloods-wise, white cell count is raised, and CRP is also raised, HB stable. Make sure you check the HB, especially when they're bleeding. On abdominal x-ray, just notes fecal loading in the rectum. CT abdomen noted multiple diverticula present in sigmoid colon. So diagnosis is likely to be diverticulitis. So if you look at the CT, it can show you these areas of diverticulum. Yeah. Right. So diverticulitis. There are a lot of terms for these things. So diverticulum is the outpouching of the mucous membrane through the muscle wall of the bowel, and diverticulosis is just the presence of the diverticulum. Diverticular disease is a symptomatic diverticulosis, so patients present with on and off abdominal pain. Diverticulitis is inflammation of the diverticulum. So we mentioned in terms of investigations would be performing some bloods, check the inflammatory markers, check the HB. Imaging, make sure you do the abdominal x-ray to exclude obstruction or abscess, which is complication of diverticulitis. Do an erect chest x-ray to rule out perforation, and perform a CT abdomen to diagnose the presence of a diverticulum. Management-wise, IV fluid, make sure they've got analgesia, give them some antibiotics. So we give amoxicillin, metronidazole, and gentamicin, but always check with your trust guidelines. Also, if they have any complications from the diverticulitis, like perforation, abscess, fistula, strictures, you may consider surgery. All right, so that's it for the cases. Now I'm just going to talk to you a bit about life as a surgical F1 and some top tips, mainly, to be honest. So I did 8 months of general surgery as an F1. Due to COVID, we weren't able to rotate to our next rotation. So some top tips for F1 in surgery, I would say come in early to prepare your list of patients. It is very important. Make sure you know where the patients are, because chances are consultants and registrars will rely on you to find out the locations and guide them to see the patients. Ensure the VTEs are done, and also make sure they all have TEDs and Clexane, because surgical patients tend to be at a high risk for developing clots. Also, prepare patients preoperatively, make sure they've got a group and screen and clotting sample the day before the surgery. Always check the INR. If it's more than 1.4, you're going to raise it to your seniors. They may ask you to prescribe some vitamin K and recheck the INR later. Hopefully, if it's hopefully it goes down to less than 1.4. And as an F1, I think you tend to be the first person to identify the sick patients in the ward. Nurses will call you if the patient is hypertensive, hypoxic, has reduced GCS. And don't ever be afraid to put out a peri-arrest call. You need all the help you can get. Raise it to your seniors once you've seen the patient, especially if you're worried about the patient. You need to trust your gut feeling that you're worried about a patient, because chances are you're right. Also, make sure to know how to contact your seniors, especially maybe get their phone number if they don't carry a bleep. There's also lots of learning opportunities when you're in surgery. get to go to theatres, sometimes even clinics. And I think it will be useful to know how to or spend some time in radiology to see how they do IR guided drainages. Also, there's also ultrasound guided cannulations that you can practice because these surgical patients, sometimes they tend to have pretty bad veins, or they're obese patients, and it's very hard to identify a good vein. So you tend to get a lot of good practices in ultrasound guided cannulation. And if you get to be very good at it at the end of F1, I think that will put you in good stead as an SHO. Also, be nice to your colleagues, your doctors, nurses, HCAs, ward clerks, and pharmacists. Pharmacists tend to pick out the TTOs or the prescriptions that you've made a mistake on, and that can be really helpful. It's also nice to have a good relationship with your colleagues, create a nice environment when you're working. So some resources I tend to use is Teach Me Surgery, Lecture Notes in General Surgery, the book, and also there's a RCS commissioning guide on acute abdominal pain, which is very useful as an F1. All right. Thank you so much for listening, and I hope you found it useful. I'll really appreciate if any of you could scan the QR code or follow the link to provide me some feedback. And also, please do not hesitate to send me an email if you have any questions about the lecture session. Thank you so much.